So this is going to be a complementary talk of Andrew has been just communicated for the last 20 minutes. So I will briefly also review what is the GI damage with antithrombotic agents, not only aspirin. Then I will touch who is at risk, because not everyone has the same risk to develop a GI bleeding. And then I will focus on the clinical trials of gastroprotectants, and I will deal with the upper GI tract, but as you probably know, and also we have bleedings associated with these compounds in the small bowel, in the colon, and then I will deal with that too. Well, most patients who start taking aspirin will develop erosions. Erosions means a small loss of mucosa without reaching the submucosa. So the question is, how many of these patients who develop erosions progress to develop an ulcer, which just is a deeper defect, reaching the submucosa? Well, this study was conducted in 5 different centers in 4 different continents. Not many patients, but there were patients taking aspirin for primary or secondary prevention, and then we found a point prevalence of 10%. Then we continued looking at this patient for 3 more months, and then among those who have no ulcer, 7.1% also develop new ulcers. So it's a quite significant number of people, but you can see here that most of these patients have no symptoms, and many of them were older and having HP infection. So the next question is, how many of these patients actually develop a GI bleeding? Well, if we focus on the data that we have, the answer is very few. Very few patients actually develop an actual bleeding. Here we have, based on these studies, the actual rates of GI bleeding in primary prevention, secondary prevention, and then age, and in addition to age, the sex. Well, you can see how those patients taking aspirin for primary prevention develop just 1 case in 1,000 patients taking aspirin for 1 year. If they are taking aspirin for secondary prevention, it's just only between 2 and 3 cases per 1,000, not many. But then things start complicated a little bit if we take into consideration age. You can see how, for example, just go to the worst cases scenario, males between 70 and 79 years old. You can see how, if we compare those not taking aspirin and those taking aspirin, it's about 7 cases per 1,000 patients taking aspirin for 1 year, which in fact is only 3 additional cases for 1,000 patients here. So 3 new cases compared to those not taking aspirin. These data essentially agree with the data that we have seen in the 3 new clinical trials published very recently, the ASPRI, the ASCENT, and the ARRIVE trial. You can see how the incidence rate ratio, the difference, the extra cases compared to non-patients taking aspirin is just 1 case per 1,000 patients years in aspirin. Also, it's just 1 case per 1,000 patients year in ASCENT, and even less in the ARRIVE trial. You can see how there was 2 cases in placebo-treated patients, 2 cases in 10,000, versus 3 extra cases in those taking aspirin, 5 cases in 10,000 patients here. So this is essentially the actual rates we have. In this recent study that we published very recently, we look at the actual incidence of upper and lower GI bleeding in patients who start taking aspirin based on the UK databases. You can see also that age is important, and even in the worst case scenario, we have more lower GI bleeds than upper GI bleeds in those patients being quite old, between 70 and 89 years old. But still, we have 2 cases, between 2 and 3 cases of lower GI per 1,000 patients year, and in case of upper GI, it's just 2 cases. If we look at how many of these bleeds were actually severe, and we define severe because they need to be hospitalized, you can see how most lower GI bleeds were actually mild because they were sent to the emergency room or they were sent to the specialist, but they were sent back home because the bleeding was not important. And only just 4 cases per 1,000 patients there were actually hospitalized with lower GI. And with the upper GI, it was a little bit the opposite. Most cases, but still only 5 cases per 1,000, were hospitalized, and a lower proportion were sent back home because they was not a severe case. And if we focus finally on how many of these cases were fatal, you could see how only 1 in 10,000 patients with lower GI bleed actually died, and only 6 cases in 10,000 patients with upper GI died. So this is what we are seeing in real clinical practice. So then, but as I mentioned before, not everyone has the same risk. Some patients have a higher incident rate that I just presented for the overall cohort of patients. Who is at risk? Andrew essentially has mentioned a little bit on this. We can define what we know the clinical risk factors in 3 groups. The main group is those patients with a history of ulcer, of peptic ulcer, especially those with a history of peptic ulcer bleeding, and also those with HP infection, because HP and peptic ulcer is very strongly related. The second group is age. Age is a continuous variable. The older you are, the higher the risk. The cutoff value could be at 70, perhaps because the actual risk for those patients being older than 70 is quite similar to those having a peptic ulcer. And then the next group of risk factor is those patients taking concomitant therapy, especially any combination of NSAID with antiplatelets, with COPSIBs, combination between antiplatelets and anticoagulants. So then the question is, how can we reduce GI complications in patients taking antithrombotic drugs? Well, we need to rely on the mechanisms, on the pathogenic mechanisms of inducing damage. If we focus on the stomach, we could see from what Andrew commented, is that in the stomach, in addition to the COX inhibition with aspirin, with the systemic effect, we have a decrease in prostaglandins. Once the topical effect also acts in the mucosal barrier, there is a mucosal damage, then there is, a penetration of the luminal content, which is acid and pepsin. But in addition, most patients, or many patients, will have inflammation of the mucosa because of H. pylori. So then, if we want to prevent this, or we want to restore the defense mechanisms of the mucosa, we need to provide prostaglandins, we need to reduce acid, and perhaps also we need to eliminate HP infection. Because in addition to this, we know that with these antithrombotic drugs, we are interfering with the clotting mechanisms once this mechanism is just broken the actual blood vessel. But we know that these mechanisms are different for the stomach and the small bowel. In the stomach, we have acid, as I mentioned, pepsin, but in the small bowel, we have no acid. We have other compounds. We have bile, we have bacteria, which seems to be also important in the pathogenic mechanisms of small bowel inflammation and ulcers. So then we need to rely on these particular aspects to provide protection to these patients and to reduce the risk of bleeding. Well, then what is the evidence we have? Let's go into review the clinical trials with antithrombotic agents in the upper GI tract first. First of all, focus on aspirin. Well, this is a very good systematic review and meta-analysis of all clinical trials focus on the effect of PPI, of effect of prostaglandins analogs, essentially misoprostol or H2 blockers, in the prevention of endoscopic ulcers, no matter whether the ulcer was induced by NSAIDs, H. pylori, or whatever factor. And you can see how the effect is a quite significant 80% risk reduction for PPI, almost a bit more than 30% for H2 prostaglandin analogs and 70% for PPI. And this is very similar for duodenal ulcer, where the effect of PPI is much greater, and similar between H2 blockers and prostaglandins and PPI for gastric ulcers. But if we focus on GI bleeding, the most important, and the most potent effect was seen with PPI, 80% risk reduction, compared to a non-significant effect with prostaglandin analogs, misoprostol essentially, and 50% risk reduction with H2 blockers. But this is the overall. Let's go into focus on aspirin. Well, if we focus on aspirin and PPI, but not on bleeding, but on endoscopic ulcer, we know that PPI, here I just put one of the PPIs, esomeprazole. You can see how after 6 months of therapy with aspirin, between 100 and 300 milligrams, those taking placebo have a 6% incidence rates after 6 months versus 1.8 for esomeprazole, and very similar in this other overall study. What about in patients with bleeding? This was one of the meta-analyses. We could see that combining all the available clinical trials at that time, we could see that PPI reduces almost between 65 and 70% risk reduction with PPI for those patients taking low-dose aspirin. What about H2 blockers? Well, this study was published by Ali Taha in Lancet. Famotidine high dose, what was 40 milligrams twice a day, also was effective in reducing gastric ulcers and duodenal ulcers. But when we focus on more severe outcomes like GI bleeding, this is one study comparing the effect of pantoprazole versus famotidine in Hong Kong, looking at the percentage of patients with recurrent adverse events after 6 months of therapy. And they compared pantoprazole 20 milligrams versus famotidine 80 milligrams per day. With pantoprazole, they didn't have any recurrence of either pectic ulcer or pectic ulcer bleeding. But with famotidine, the composite between dyspepsia and bleeding ulcer or erosions, you can see which is 20%. So again, pantoprazole better than famotidine. However, there was a recent trial published by our friend Francis Chan in patients who have a previous ulcer bleeding, and then these patients were put on aspirin and on famotidine or rabeprazole. And then the conclusion of the study was that there were no differences between famotidine and pantoprazole, or rabeprazole, after 12 months of therapy. But you could see, although there were not statistical differences, how rabeprazole have, almost a flat line difference to famotidine, which was a little bit increased compared to pantoprazole, to rabeprazole. But still, it's important to see, how many patients were involved in this study. Not many. And if we focus on the actual endpoints, so this is for the gray line is for GI bleeding, recurrent upper ulcer GI bleeding, and the white was for endoscopic ulcer, and the white, the black bars were the composite, recurrent upper GI bleeding or endoscopic ulcer, you could see how still there are differences in favor of omeprazole. I think that this study there was a problem of the sample size. But if we look at the meta-analysis between PPI and H2 blockers, you could see that for prevention of upper GI lesions in general, PPIs are much better than H2 blockers. There was an 80% difference in favor of PPI compared to H2 blockers. What about with thienopyridines? We don't have any specific study focused on the combination of thienopyridines plus PPI versus placebo. The only thing we have is this study that was already commented by Andrew, in patients who have a previous ulcer bleeding with, after HP eradication. These patients, which are at the higher risk, they were put on clopidogrel alone versus aspirin 100 milligrams plus esomeprazole 20 milligrams. And you can see how after 12 months of therapy, there was a big differences in favor of the combination of aspirin plus esomeprazole versus clopidogrel alone, which means that if you have a high-risk patients, no matter whether you put this patient on aspirin or clopidogrel, probably you will need to add a PPI. What about the combination of clopidogrel with aspirin and PPI versus no PPI? Well, the only study only clinical trial we have is the COGENT study. And the COGENT study, which unfortunately was interrupted before the end because of problems with financiation, you could see in the probability of being free of primary endpoint for GI events, which essentially was GI bleeding, those patients receiving clopidogrel plus aspirin plus omeprazole have a much better outcome than those without omeprazole. This didn't affect the cardiovascular endpoints, no differences, which have been already commented. Probably what you are seeing in the laboratory with the interaction of a PPI with clopidogrel may have no impact on clinical outcomes. And also in this sub-study of the COGENT study, we could see that no matter the dose of aspirin is less than 100 milligrams or equal to 100 milligrams or more than 100, the PPI effect is also the same, very effective. Well, what about H2 blockers and PPI in this particular patient receiving dual antiplatelet therapy? Well, this was one study also conducted in Hong Kong for those patients developing an acute coronary syndrome or MI, and they were randomized to receive esomeprazole 20 milligrams versus famotidine 40 milligrams twice a day. And after 1 year of follow-up, you could see how those patients receiving a PPI will actually have a much better outcome than those receiving famotidine. But still, it's important to see we are just dealing between 90% and 100%. This is just less than 2% recurrence of bleeding versus about 9% in the famotidine group. Okay, and finally, what about those patients receiving anticoagulants? Well, we need to rely on the only study we have, which is the COMPASS study. This is the outline of the COMPASS study. So you know very well, because this has been commented today, there were 3 arms, rivaroxaban 2.5 milligrams BID versus rivaroxaban 5 milligrams only, or aspirin. And then there were almost 10,000 patients who were actually taking PPI, and these were excluded from this analysis. And then those not receiving PPI, they were randomized to receive pantoprazole 40 milligrams or placebo. And then the conclusion is that there were not differences between these 2 arms. So no differences between those patients receiving PPI, pantoprazole, versus those not receiving pantoprazole. What was the problem? This means that pantoprazole or the PPI is not effective in reducing GI bleeding in patients receiving rivaroxaban plus aspirin or aspirin alone. Well, I think that one of the problems is the outcomes of the composite outcome, they were the primary endpoint. To me, this was like some kind of totum revolutum. There was a mix of different things. Overt GI bleeding with GI origin confirmed by endoscopy, overt upper GI bleeding of unknown origin. We know that in these cases, probably most of these were due to, I will say, vascular lesions. Also, bleeding of presumed occult GI origin with documented decrease of the hemoglobin. Probably there were small bowel bleedings, symptomatic gastroduodenal ulcers, GI pain with underlying mucosal erosions, Straussian perforation. Okay, to me, the only two outcomes that could be affected by PPI was probably this one, overt GI bleeding with confirmed endoscopy lesions and symptomatic gastroduodenal ulcers, because the post-hoc analysis of this study actually show a clear advantage of pantoprazole in those cases of bleeding due to gastroduodenal lesions, because we need to know that PPI, the main effect of PPI is reducing acid, and the acid actually only in the stomach or the upper duodenum. And when we look at the other outcomes, GI bleeding due to gastroduodenal lesions, erosions, ulcers, or the combined post-hoc outcomes of these three, you can see how pantoprazole is actually effective. Okay, what about the small bowel? And this is the final area I'm going to review. Well, we know that PPI will not, or H2 blockers will not act on the small bowel. What about misoprostol? Misoprostol is an exogenous prostaglandin that is added to the drugs being taken in combination. And this study was published recently also from the Hong Kong group, looking at patients who had a previous ulcer bleeding due, or a previous GI bleeding due to small bowel ulcers or erosions. And they were put on misoprostol. And they were followed for 8 weeks. And then you can see how those patients receiving misoprostol high dose, 200 micrograms 4 times per day, have an increased number of ulcers healed seen by capsule endoscopy after 8 weeks of therapy compared to those receiving placebo. And here you have the individual cases. So then if you look at, sorry, can I go back? Oh. Well, anyway, it was a sub-analysis of this. The conclusion was that misoprostol was effective. But the problem with that is that if you look at this axis, you can see that only 30% of those ulcers were actually healed. 70% were not healed. These patients were taking these drugs also with aspirin. So then 70% of the ulcers were not healed, which means that misoprostol is effective, but probably not very much. And the only study that we have with different compounds, with ribamipide, which is a compound not available in Europe, not available in the USA, only available in Asia. This is a compound which essentially is a gastroprotectant because it increases the mucosal defense of the small bowel and the stomach. And the conclusion of this study published in PLOS ONE was that compared to placebo, ribamipide high dose were better in healing ulcers from the small bowel in patients taking low-dose aspirin. When you look at the graphs, it seems like this is the opposite. With ribamipide, actually you have an increased incidence of ulcers, but the overall is a small reduction. Still, I will say that this is not very encouraging results. So in summary, I will say that anti-secretory agents have shown to reduce major GI events overall and in aspirin or aspirin plus clopidogrel users, that PPI are clearly more effective than any other agent, that the effect of anti-secretory agents in patients taking anticoagulants has not yet been proved in clinical trials. We do have some epidemiological studies suggesting that PPI are also effective in reducing bleedings coming from patients taking anticoagulants, but clinical trials still have not shown this. And then antisecretory agents have no effect on GI damage prevention associated with antithrombotic agents in the small bowel, and further investigation is needed with these new compounds or other agents that may come to the clinical practice. And thank you very much for your attention.